Hi guys, I will show you some case. I recognize that I did not make the right surgical choice in treating a subtrochanter fracture. You can see this x-ray, a little bit community the short transverse one. This is actual view, the subtrochanter fracture spike 1. This is CT scan, like this. And I performed the surgery like that. We use legendary PFN, not long one, and the two locking screw to improve the stability. And this is lateral view, but you can see the little bit spike and not exact, the not not beautiful, a little bit, and later I found that anteroportal, not exact one. And after 3 weeks later, during the first 3 weeks post-operative, she had a minimal pain, was mobile, and managed daily activities with the use of a wheelchair. And she was happy. And when it was uncertain whether the cause was deep vein thrombosis or myocardial infarction, and her vital sign could deteriorate over several minutes. So I prescribed 3 aspirin tablets were administered as an emergency measure. Her vital signs stabilized, so she was transferred at the hospital. Unexpectedly, vital signs instability developed, and this was subsequently found to be due to an acute pulmonary embolism resulting from deep vein thrombosis. This is the final diagnosis. The patient was presented with an option of pharmacological injection-based thrombolysis or surgical removal of the chest embolus. She selected the surgical approach and subsequently underwent operative management. She completed the surgery and recovered well, and about a month later, she returned to our hospital. You can see these pictures. This one, the broken nail over there. Totally probably 2 months later after surgery. In case of non-union or implant failure, the patient's post-discharge lifestyle pattern must not be overlooked. She said, while lying obliquely in bed, she tended to slide down and therefore repeatedly use her legs to push herself upward. She reported that she repeatedly performed leg raising exercise, but we have to consider surgical factors. Surgical factors to consider in cases of broken nail. I think a more better option, a long PFN or open surgery with a plate. A similar outcome occurred 10 years ago in my experience, but it was overlooked. I forgot. Given that the fracture was a short transverse and located proximally, the selection of a short implant seems to have been one factor. The surgical options I am currently considering are as follows. After removal of a broken nail, in case in sometimes I consider about impossible to remove the broken nail, but later I will tell you. After removal of a broken nail, one option is long PFN, or an ORIF is planned with the use of a long length plate for the management of left distal fusion fracture. You know the long span plate, the left side one. This is the right side subtrochanter fracture. So you can use the left side distal long plate with a reverse applying that. The third one is a DHSN plate, but it has also risk for non-union and broken plate. I had seen that before. Approximately 10 years earlier, a similar subtrochanter fracture was managed with a short PFN, which resulted in non-union and a nail breakage. The complication was subsequently resolved through DHS and side plate fixation. But I had an experience on another case. There has been case in my experience where the use of DHS and plate led to non-union as well as plate failure. So, in cases of subtrochanter fractures of this pattern, the use of a short PFN should never be considered. This is other options: ORIF, then CRF, long PFN or long plate, reverse side, reverse supply with. In our country, we have to use the left side distal femur fracture plate. So, as it is judged that surgery should only be performed after the patient can discontinue the medications prescribed following chest surgery. So, the procedure has not yet been undertaken. I'm waiting next operation. Be careful.